thank you very much for the invitation and for hosting such an important seminar. So I have also prepared a presentation on how to design clinical trials in MetALD. Thank you for not doing the same as Wani.
No problem.
So here are my disclosures. So what I would like to discuss with you today is first thing is our experience with MetALD in clinical trials. Then I will go through some key aspects, at least how I see what is important when comparing to clinical trials in MetALD. That's recruitment and compliance. It's about how to assess alcohol intake, and then finally how to define outcomes. And then I will briefly touch on the drug pipeline. So our experience. So 3 or 2 years ago, we published this study, which is a randomized double-blind placebo-controlled trial in people with alcohol-related liver disease. We treated them for 18 months with rifaximin. You see here that we did baseline assessment, and then we randomized people either to rifaximin or placebo, and then we treated them for 18 months, and then we repeated the assessment to assess the efficacy of the intervention. But what I would like to discuss with you here is, as already mentioned by Professor Wang, is that when you categorize these people according to the SLD nomenclature, this was published before the SLD nomenclature, approximately 40% of the population actually had MetALD at baseline. However, looking at a patient here from the trial, you see here the alcohol intake in grams per day, and then how it turned out during the trial. And this is one patient. You see here, actually, if it was categorized at baseline, it was in the MetALD spectrum. However, during most of the trial, the patient was actually in the MetALD spectrum. I'll just use this one. So therefore, a lot of people with an excessive alcohol use have MetALD in periods of their disease, I would say. We also have experience from a new trial called Galapagos-Bio, which is just accepted for publication in Nature Communications, and it will probably soon be published. So now let's have a look at the key aspects. First of all, recruitment and compliance, and alcohol assessment, and finally outcomes. I think we cannot discuss how we should design clinical trials in MetALD without discussing how it has been done in MetALD, because there is a bright drug pipeline here for MetALD. You all know the resmetirom trial and the Essence trial with GLP-1 receptor agonist, and also the FGF21, as Dr. Singal just mentioned. But what are the differences then? At least what is introduced in the literature is that the prevalence of MetALD is very high. We have now learned from Professor Wang that it may be that it's not that high, and the MetALD prevalence is maybe higher. However, there's also a discussion on how is compliance in this group of patients with an excessive alcohol intake. It is presumed to be high in MetALD compared to MetALD and ALD, where it's low. Then, of course, the alcohol assessment. It has been considered non-necessary in MetALD. We now recognize that it may be necessary also in this population, but it is, at least we can all agree on that it's important in people with MetALD and ALD. And then finally, the outcomes, because there is a low level of liver-related outcomes in MetALD compared to MetALD and ALD, as we just learned. But there's also this, that MASH is accepted for accelerated drug approval, which is not the case for people with MetALD and ALD, and therefore the design in terms of outcome have to be different. But let's have a look at recruitment and compliance. You just saw this figure showing that MetALD is not as prevalent compared to MetALD, so it may be difficult to recruit a lot of patients in this population. However, if we look at alcohol report discrepancy, you see that among patients classified as MetALD, the underreporting range from 10% up to 55%. And this actually turns into that if you look at the uncorrected data, MetALD is much more prevalent compared to MetALD and ALD. However, if this is the true case, then MetALD and ALD is highly prevalent, making it probably feasible actually to recruit patients for these kind of trials. Now let's have a look at our experience. So we screened 1,900 people with excessive alcohol intake. Hereof, you see here 260 plus 160, 36 actually were eligible for the trial, and 1/3 would like to participate. Likewise, in the new study here, we screened around 600 people with excessive alcohol intake, and around 150 were actually eligible to participate, and 1/3 would like to participate in the trial. What about the compliance then? Actually, we included 136 patients, and 54 in each group completed the trial, leading to a dropout rate of 21%, which is comparable to a lot of other randomized controlled trials. In the Galapagos Bio trial, we included 56 patients, and hereof 41 patients actually completed the study, leading to a dropout rate of 27%. So I think we can conclude that compliance is actually acceptable in this group of people. Then what about the alcohol assessment? So I think we can all agree that alcohol is the driver of MetALD and ALD. These are just very simple data telling that the 10-year mortality among people who are abstinent is only 12%, and it's more than double as high in people who actually relapse to alcohol consumption. And therefore, alcohol is key to assess in clinical trials. But how do we do this? There are some subjective measurements and some objective measurements. I think we will only look at those that are recommendable for quantification. So let's start with the self-reported alcohol intake measurements. So we have the timeline follow back. It's a retrospective tool. It's well validated and recommended by the FDA. It's a calendar. It's a simple calendar where you fill in how many drinks you have had each day up to 90 days. And data shows that the accuracy does not decrease over time, but it's time consuming. Then we also have these new alcohol drinking diaries, which are prospective. You can have them on an app. They are more accurate compared to timeline follow back in short-term studies. However, the accuracy may likely decrease in long-term studies because people are getting tired of filling in this every day. Then we have the direct biomarkers. And here you see the direct alcohol biomarkers here on your left side, and then you have the detection windows here at the right side. And as Professor Singhal mentioned, that PEth is probably the best way actually for use in clinical practice, but also in clinical trials. So how can you then set up a clinical trial where you actually quantify alcohol? So what I would recommend is that at baseline, you should do a timeline follow back, but you should also include the long-term history of excessive alcohol intake, because we know that people who have had an excessive alcohol intake in the past may also have it in the future. And then we also have the phosphatidylethanol as a direct marker to support whether these reportings are actually correct. Then during the trial, if it was an 18-month trial, I would recommend that you do these measurements several times during the study. You will do an alcohol drinking diary at least few days between each visit. And then you have the phosphatidylethanol PEth, which should be measured at every visit. And then the timeline followed back to triangulate the quantification of alcohol intake. What about the outcomes? So please remember that the condition MetALD and alcohol-related liver disease are not accepted for accelerated drug approval, which means that a phase 3 trial should include clinical endpoints. And this is feasible, actually, to run a phase 3 trial and then have clinical endpoints. If we look here at the general population, which was also mentioned before, that MetALD has a higher risk of at least liver-related events. We had the same experience here, where we also saw that the group with classified with MetALD had a higher risk of hepatic decompensation compared to MASLD. A new study from the US veterans showed also that the MetALD had a higher risk of major adverse liver-related outcomes. So it seems like it's feasible actually to conduct a study with the significant number of liver-related events in people with MetALD and ALD. So what about a phase 2 trial? What is the purpose here? So the purpose is to establish evidence of efficacy and safety to support a phase 3 trial. So overall, it's important that the phase 2 trial have evidence that support those that should sponsor the trial, the phase 3 trial, actually to go into this and see clinical endpoints. And there are a lot of potential efficacy measures here. You could go for histology like in MASLD, fibrosis score, improvement in fibrosis score, resolution of steatohepatitis, improvement in alpha smooth muscle actin, which is a marker of fibrogenesis, but also steatosis. But steatosis is probably not a good marker. Then also you have the non-invasive tests here. In the ELF test is a possibility, the transient elastography, ProC3, and liver-pro, but also FIB4 could be a measurement of efficacy of a drug. So now let's have a look at the drug pipeline. As far as I'm aware, there are 2 announced clinical trials or sponsored by pharma companies running right now. So the first one is Novo Nordisk. They actually completed the recruitment, but the trial is still active. And here they assess the efficacy of FGF21, cagrilintide, and semaglutide alone or in combination in people with alcohol-related liver disease. Also, there is a GSK-sponsored trial called Starlight, where they are assessing the efficacy of an siRNA targeting PNPLA3. And what is important here is this for alcohol-related liver disease or MetALD? If we then look at the inclusion criteria, here you see that the alcohol level is actually also including the upper range of MetALD, ranging from 40 to 50 grams per day, male, female. It's not mandatory to have metabolic risk factors, but it's acceptable. And the primary outcome here is actually a change in ELF's test of 0.5. Then when we look at Starlight, they are including all the spectrum of people with MetALD and ALD. Once again, it's not mandatory to have metabolic risk factors, but it's acceptable. And here, the primary outcome is the difference in TE, transient elastography, after the study compared to baseline. So with this, I'd like to conclude that recruitment is feasible and compliance is acceptable in people with MetALD in clinical trials. Alcohol should be assessed in detail. Liver-related outcomes are common and can therefore serve as the primary outcome in phase 3 trials. And finally, the first drug trials in MetALD and ALD are running, and probably we have the first results from the Novo Nordisk trial within 1 year. With that, I would like to thank the audience and thank you for your attention.